Hi, welcome to Point of Care Nurse. My name is Gozi, and we're going to talk about valve surgery for the CCRN exam in this video. When would a patient need valve surgery? Usually, when they have really severe stenosis in a valve or really severe regurgitation in a valve. The valve could either be repaired or replaced. So, in the case of repair, the surgeon would try to make the native valve work somehow. They could do this by valvuloplasty. They could try to make the leaflets of the valve more prone to opening. If they're fused together, they could separate the leaflets of the valves. So that's repair, some things they could do to repair the valve. They could also totally replace the valve. Now, when they replace the valve, it could be done with a mechanical valve or a biological valve. The mechanical valve is usually stainless steel, while the biological valve is usually harvested from cows or pigs. Human cadaver valves that have been prepared for this very purpose could also be used as well. Now, mechanical valves last longer than biological valve. The thing with mechanical valves is that the patient will need to be on anticoagulation for the rest of their life because they're at high risk of developing a thrombus. So they need the anticoagulation for life permanently. The mechanical valves are also relatively easy to place, and they're usually more reliable or very reliable. The biological valves, on the other hand, don't last as long as the mechanical valves. However, the patient only needs short term anticoagulation. Unlike the patients with mechanical valves, they have to be on anticoagulation for the rest of their life. The one thing that the patients with the biological valve will need is lifelong antiplatelet therapy. So, like, they'll be on aspirin forever. And like we said before, the mechanical valves last longer than the biological valves. That's because the biological valves wear down faster, especially when they're in a system where there's high pressure. They're going through high pressure for long periods of time. Obviously, it's not made of steel, so it will wear down. Unlike the mechanical valves that are made of steel, they can tolerate high pressure systems better than the biological valves. So that's kind of a compare and contrast of the mechanical valves versus the biological valves. A few things to consider after a patient has had valve surgery are: one, this patient has, so when the patient has aortic stenosis or mitral valve regurgitation, any kind of issue with forward flow, if there's the case where the blood is not flowing forward as it should, like in stenosis, there's backup of blood. Now, if there's a case where not all of the blood is flowing forward, like in regurgitation, some blood is coming back, we also have more volume sitting in the ventricle. So then, in this case, someone that has had um, aortic stenosis for a while, or someone that has had like severe valvular regurgitation, they've had a lot of volume sitting in the in the ventricle and probably backing up into the atria. So these kinds of patients are used to having a lot of volume in their hearts. So once they get the valve surgery, we don't want to drop the amount of volume the heart usually holds right away. So that's preload. We don't want to drop their preload right away to normal values. It's something that should be done gradually over time. If not, they could get hypotensive. So that's one thing to keep in mind postoperatively. Another thing is that we already spoke about this before. If the patient gets a mechanical valve, they need lifelong anticoagulation therapy. If the patient gets a biological valve, they need antiplatelet therapy for life. They will also need anticoagulation, but only for a short time. And another thing to consider, I think I was doing questions when I was preparing for my CCRN exam, and I had a question about this patient got some kind of valvular surgery replacement. and the patient is anxious, and the question was asking, what would you teach the patient? So the answer to that question was that you had to teach the patient either that they needed lifelong antiplatelet therapy, or they needed lifelong anticoagulation therapy. So that's just one thing to keep in mind if you come across a question like that asking you what to teach the patient, or one important thing the patient has to do if they get this kind of surgery. They have to maintain whatever therapy they need for either a mechanical or a biological valve, so that it can last them longer and they don't develop any um, complications due to like thrombus formation. So that's something to keep in mind. One last thing to consider is that um, whatever valve is replaced, the mitral, tricuspid, and aortic valves are close to conduction pathways in the heart. So we're talking about the SA node, the AV node, and all of that. So if the surgeon goes, working around those areas, there is a possibility that the conduction pathways may get damaged, or something could happen. So when they come back out, you need to keep an eye on their cardiac rhythm, make sure the rhythm is organized, make sure there are no blocks and there are no conduction disturbances. The patient might need a pacemaker if, like, the SA node is damaged and it's not firing properly. They might need a pacemaker after this kind of surgery. It could be temporary, it could be temporary, or it could be permanent. So some things to keep in mind in case you get a question on this topic. In 2011, a surgical procedure called TAVR was approved for aortic stenosis. So TAVR is TAVR, transcatheter aortic valve replacement. So in this procedure, patients with aortic stenosis get a valve placed into the I'm gonna try to explain this properly, but those that know TAVR will know what I'm trying to say. They get a So in TAVR, the patient will get a valve. It could be uh, either a from a cow or a pig, a collapsible prosthetic valve, and is placed on top of the valve that isn't working. So essentially, they open up the valve that's not working and place this new valve in there, and it kind of opens up and starts working, if that makes sense. So um, for this procedure, the surgeon would go through the patient's femoral artery. So it's kind of minimally invasive as opposed to them for going for a full blown heart surgery, cabbage style, where they open the chest to access the valve. It's less invasive. But not everyone qualifies for this surgery. Patient has to be high risk for open heart surgery to qualify for a TAVR, or they have to be intermediate risk, where the surgeons will decide at their discretion if they're going to do a TAVR or if they'll go for a full blown open heart surgery. Patients that are low risk for now don't qualify for the TAVR surgery. Something to keep in mind in case you encounter this on the CCRN exam. So for TAVR, the TAVR is only for the aortic valve. So it's called transcatheter aortic valve replacement. So this is a replacement, not a repair. So for the TAVR patient that's post TAVR surgery, remember the surgeon is going to go through the femoral artery. So assessment wise, intervention wise, for the nurse, for us, is monitoring the patient for bleeding. Patient might have retroperitoneal bleeding. Patient might have hematomas in the area. Arterial occlusion. We have to check for heart blocks, just like if they had a valve replacement or valve repair. Just because the valves are close to conduction pathways, they might have some conduction abnormalities. So we want to look out for heart blocks. Patient might have a stroke, acute kidney injury. So we want to monitor their neurostatus. We want to check their urine output. Um, Now, regarding the surgeon accessing the femoral artery, We also want to do neurovascular checks on the patient's extremity that was affected. We want to make sure the patient can move the leg, their toes, and things like that. We want to make sure the patient has a good pulse after the surgery. And we also want to make sure that the dressing in that area is clean and dry. One rare complication of TAVR is a paravalvular leak. So, this is when the bioprosthetic valve that was placed in the native valve doesn't have a complete seal around it, meaning that blood is leaking around the bioprosthetic valve that was placed. So when the ventricle ejects blood into this bioprosthetic valve, blood goes through the valve and around the valve into the aorta and then into the body. So in this case, the leak may be small, it may be large, but one way to detect it is obviously by doing imaging studies. Another way to detect it is by doing labs. So if the leak is large enough, the patient's hemoglobin might drop. Patient might have signs of hemolysis because when the blood gets pushed through that small area around the bioprosthetic valve, between it and the native valve, those blood cells could break down, and then you'd have a case of hemolytic anemia. But this happens very rarely. It's a rare complication of the TAVR procedure. One last thing for the TAVR procedure is that the patient will require dual antiplatelet therapy, meaning they'll need two different types of antiplatelet medications, usually aspirin and clopidogrel. They will need aspirin for life, and the other antiplatelet they will need for about 3 to 6 months. This concludes our video for valve surgery for the CCRN exam. I hope you found this video helpful. Please like, share, and subscribe, and I will see you in the next CCRN video. Bye bye now.